Hi everyone, Ryan Rubino here. Today I'm going to talk about stretching risk adjustment to its breaking point. And the first thing that comes to my mind when I think of risk adjustment typically is its relationship to top-line revenue for value-based agreements. But today I'm going to talk about kind of some more fundamental use of risk adjustment, which is really to be able to compare the costs associated with one provider panel to the costs associated with another. And understanding that those panels don't have the same complexity and risks associated. If you have a sicker, older panel, you would expect those patients to be spending more on their healthcare. And risk adjustment allows us to take all of those conditions that are associated and adjust those patient panels so that we can have an apples to apples comparison as if they had the same risk involved, and understand how those two groups are performing. The way this works is by having risk adjustment factors, which take into account all of the various conditions associated with a particular patient panel, adding them up, averaging them, and then coming up with an overall risk factor that can be used to normalize populations. So say you take this example here, where the cost of our diabetic patient population is about $550 PMPM. And if you apply the risk adjustment factor associated with that patient panel, which is about 1.5, you would bring down and risk adjust those costs down to around $370 PMPM, which is actually below our baseline for the general population. So in this example here, even though the costs for this diabetic population are higher, we're actually doing pretty well. We're actually doing better than average for this population. And the reason that this works is because if you have a large enough patient population, you can take all of those conditions into account and risk adjust the overall population. So say you take a diabetic population, for example, you would expect them to spend more on inpatient stays, on medications, on specialist visits, and on durable goods and a handful of other categories. And if you add all of those up, you would expect that diabetic population to cost about 1.5 times the average cost of the general population. However, if you take this spend and you start to adjust it by category, and you spread that adjustment evenly across categories, you would be saying that you would expect inpatient spend to be 50% higher, outpatient spend to be 50% higher, pharmacy costs to be 50% higher, ancillary, same thing. And this really is not the case. And this is where risk adjustment and using these risk adjustment factors to predict certain types of costs starts to break down. The reality, and this is based on real benchmarking data for a diabetic population, is that you would expect your inpatient costs to be about 59% more, pharmacy cost 140% more, outpatient ancillary increase less so. And this really, it makes sense in that you would expect if someone has a particular condition that there would be certain risks that are going to have more significant costs associated with it, and there might be other preventative steps that have costs associated with them as well. But if you risk adjusted everything by that blanket 50% and tried to look and compare costs within one of those categories, you really may be making a significant mistake. And you end up with a situation where there could be a huge gap between reality and where you risk adjusted some of these costs to. So say you take pharmacy spend and you had risk adjusted that down by 50%. You may compare that to the general population and think that there is a significant overuse of drugs and medications, when in reality that's what you would expect with a diabetic patient population, and maybe you're even doing better than average as well. So it's really important to look at the particular category of spend that you are interested in, and either don't use risk adjustment factors to make these inferences, or work with a data science team to come up with an appropriate set of benchmarks that is targeted for the particular set of analysis that you're trying to do. So the main takeaway here is that risk adjustment factors are an incredibly powerful tool to be able to use to predict and analyze healthcare spend, but know their limitations and be very careful if you start to bump up into some of those limitations so that you don't draw inferences that are inaccurate. And the example that we went through here for diabetics has similarities to a lot of other high-risk conditions where you would expect to see kind of an unequal distribution of where some of those costs are going to increase or decrease as a result of that condition. I hope you found this helpful today. Always interested to hear what you think, and please feel free to leave a comment down below. And thanks so much for listening, and have a great day.